بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, now we will continue the topic of MRI or imaging MRI of the knee joint. We have started the evaluation of the knee joint, and we discussed the anatomy as well as the technical aspects and the meniscal pathology. Now we are going to continue this part discussing the ligamentous lesions. And we have three groups of ligaments in the knee: the cruciate ligaments, the collateral ligaments, and the patellar retinacular ligaments. Starting by the cruciate, and one of the important cruciate ligaments is the anterior cruciate one, and this ligament is particularly commonly injured compared to the posterior cruciate ligament, which is more tough and less frequently injured. You know that the anterior cruciate ligament is attached to the posterior aspect of the femur and extends to insert in the anterior aspect of the knee. The ligament should be stretched and should be parallel to the roof of the intercondylar notch. This is the roof of the intercondylar notch, and the ligament should be stretched and should be parallel to the roof of the intercondylar notch. And in the coronal images, whenever you look in the notch, you will see the anterior cruciate ligament related to the lateral femoral condyle, and the horizontal part of the posterior cruciate ligament is attached to the inner aspect of the medial femoral condyle, as I have mentioned in the sector of the anatomy. Then if you want to see the anterior cruciate ligament, you first identify the posterior cruciate ligament, which is a constant cord-like low signal structure attached to the posterior aspect of the femur, going to the posterior aspect of the tibia. Then either you go an image before or an image after, looking for the anterior cruciate ligament. You will find the anterior cruciate ligament in one of these two images, either here or there. Then in this particular example, you can see this is the anterior cruciate ligament attached to the posterior aspect of the femur, going to the anterior aspect of the tibia. Then I have mentioned this example before. If you put your finger on the posterior cruciate ligament, going an image before and an imaging after, and you cannot identify the anterior cruciate ligament, then there are one of two possibilities. Either the anterior cruciate ligament is torn, or the examination is performed wrongly, and the technician has selected the wrong angle for scanning in the sagittal plane. Then in the eras of the beginning era of MRI, we used to bring the patient back and we sit beside the technician to set the right angle for ACL identification. But now you can easily look in the coronal image in the intercondylar notch. Then if the anterior cruciate ligament is present, as here, then you know that this is a wrong angle selection. But if you cannot see the anterior cruciate ligament in the notch and you see only the horizontal part of the posterior cruciate ligament, then you know this sign is known as the empty notch sign, and then you know that the anterior cruciate ligament is torn. Then how to select the right angle for ACL or for sagittal adjustment, sagittal sections, in order to be sure that you will show the anterior cruciate ligament if it is present. Then you go to the axial images and you draw a line tangential to the femoral condyles. Then you draw another line perpendicular to this one. Then you select an angle which is 10 degrees to the medial aspect of the knee. From this perpendicular line, you select an angle about 10 degrees towards the medial aspect of the knee, towards the medial side of the knee. Then if you are cutting the sagittal images like this, you will definitely cut the course of the anterior cruciate ligament, and if it is present, it will be shown clearly in the images. Then if you look to this image, and in this particular example, you can see both anterior and posterior cruciate ligament appearing in the same section, but frequently the anterior is seen in a different image than that where the posterior cruciate ligament can be identified. Then if you have selected the right angle of scanning, then you will see the anterior cruciate ligament like this. But sometimes you can see the anterior cruciate ligament like this, especially the femoral attachment appears bulky, but the ligament is black, maintaining its normal signal, and is stretched. Then this is a partial volume average. You are cutting part of the femoral condyle with the insertion site of the anterior cruciate ligament. Then it will appear like this, and this is considered normal and is not diagnosed as ligamentous injury or sprain or any of the things mentioned in the reports, and this is also normal. You see, this is the anterior cruciate ligament, which is stretched, and this femoral attachment is bulky because of the partial volume averaging. You are cutting part of the femoral condyle together with the insertion site of the anterior cruciate ligament. Then when you can easily diagnose ACL rupture, and there are only one criteria for the rupture of the ACL, which is rupture of the ACL. Then if you look here and you see this is the course site or the anatomic site of the anterior cruciate ligament, and this is T1, this is proton density, and this is T2. Then if you look carefully, you can see that there is fluid signal within the anterior cruciate ligament near its femoral attachment. The ligament is bulky and its signal is different, and here you can see it is of intermediate signal, somewhat increased signal in the proton and in the T2 weighted image, and this means that there is rupture of the anterior cruciate ligament. Then if you look in the intercondylar notch, and you cannot see the anterior cruciate ligament, and instead you see some fluid, and also you can identify the horizontal part of the posterior cruciate ligament, and this sign, as I have said, is known as the empty notch sign, because ruptures of the anterior cruciate ligament are due to trauma. Then you can see the effect of trauma in the bone marrow in the form of bone marrow edema and contusion, which are commonly seen in the femur and tibia, but sometimes they can be seen in the tibia alone, and less commonly they are seen in the femur alone. And look at this example. This is the normal appearance of the anterior cruciate ligament, which is stretched parallel to the roof of the intercondylar notch, but this ligament is disrupted at its femoral attachment. You can see fluid signal near the insertion site or the attachment site of the anterior cruciate ligament to the femur. Then the distal fibers of the anterior cruciate ligament are seen lying flat against the tibial plateau. And this is total discontinuity of the ACL, denoting disruption. And in this example, you can easily appreciate that the anterior cruciate ligament is torn at its mid portion, and the ligament is defective here with diffuse swelling of the ligament itself, as well as increase in its signal intensity. Then look at this example. Here you can see the site of the anterior cruciate ligament is replaced by abnormal signal, and there is a defect in the mid portion of the ligament. In the coronal images, you cannot easily identify the anterior cruciate ligament, nor in the stair or in the coronal T2 weighted images. Also, you can appreciate the presence of bone marrow contusion in the femoral condyle, as well as in the opposing surface of the tibial condyle, which is known kissing contusion. Then what is empty notch sign? This is the normal notch, where you can see the anterior cruciate ligament adjacent to the lateral femoral condyle. the horizontal part of the posterior cruciate ligament attached to the medial femoral condyle. But here you can see the horizontal part of the posterior cruciate ligament only, and you cannot identify the anterior cruciate ligament, and this is known as the empty notch sign, which is diagnostic of ACL rupture. The empty notch sign can be also seen in the axial images, as you can see here. This is the anterior cruciate ligament, which is normal, and in this example you see the site of the ACL is replaced by abnormal increased signal denoting its rupture. And this is also another example of rupture of the anterior cruciate ligament at its mid portion, which is occupied by fluid signal, as you can see. Then, can you diagnose ACL rupture by plain X-ray? And this is feasible. If you look here, you can see there is a avulsion of the site of the attachment of the anterior cruciate ligament to the tibia. And whenever you see a fracture in the region of the tibial spine, you may assume that the attachment site of the anterior cruciate ligament has been avulsed. Then this is the diagram showing the appearance. This is the anterior cruciate ligament, and this is the attachment site of it to the tibia. This can be more better appreciated by CT images, especially in the 2D coronal and sagittal reconstruction, where you can see a avulsion of the attachment site of the anterior cruciate ligament. And this is MRI of avulsion of the attachment site of the anterior cruciate ligament, and the ligament is lax. As you can see here, there is avulsion of the attachment site of the anterior cruciate ligament, and you can also appreciate the presence of some hemorrhage and the fluid within the joint. And sometimes you are in doubt if the anterior cruciate ligament is torn or not, and there are many supportive signs for confirmation or exclusion of ACL rupture. I think that the most two reliable signs are the presence of bone contusions, because the ACL rupture do not occur spontaneously, and what's known as anterior translocation of the tibia, which corresponds to the drawing sign performed by the clinician. Then, because the ACL tear are post-traumatic, they are usually leave some contusions in the bone marrow, and these contusions are one of the confirmatory signs that ACL has been ruptured, especially if they are in the tibia as well as in the opposing surface of the femur. And you should remember that all the signs of ACL rupture are seen on the lateral aspect of the knee. Most of the signs of ACL rupture are seen on the lateral aspect of the knee, in the lateral femoral condyle, the lateral tibial condyle. Then you see here, bone marrow contusions are present in the tibia and in the femur at the level of the lateral meniscus on the lateral aspect of the knee. The contusion is black because of bone marrow edema in the T1 and bright in the T2. Contusions are better seen in stair images. And then the other sign is known as anterior translocation of the tibia. And in order to test for ACL rupture, the patient is set at the edge of the table, and the clinician tries to draw the leg anteriorly. If it can be drawn anteriorly, this is known as the drawing sign, which is a sign of ACL rupture. Normally, in the MRI images on the lateral aspect of the knee, if you draw a line from the posterior surface of the femur, it will touch then the posterior surface of the tibia. But if the anterior cruciate ligament is torn, the tibia will be displaced anteriorly, and there will be a distance between the posterior surface of the femur and the posterior surface of the tibia, and this is known as the translocation distance. If this distance is more than 5 millimeters, this is one of the supportive signs of ACL rupture. Then on the lateral aspect of the knee, normally if you draw a line from the posterior surface of the femur, it will touch the posterior surface of the tibia. But if the anterior cruciate ligament is torn, the tibia will be displaced anteriorly, and there is a distance between the posterior surface of the femur and the posterior surface of the tibia. Bony avulsion of the site of the attachment of the anterior cruciate ligament is one of the diagnostic signs of ACL rupture in the plain X-ray. Another sign, which is known as the second fracture. The second fracture is a very small sheet of bone which is avulsed from the lateral tibial condyle, which is best seen in the plain X-ray and can also be, of course, seen by CT and is difficult to be appreciated in MR imaging. This sign, this second fracture, is supportive by about 75% to 100% of ACL rupture. Then you can appreciate the second fracture in the plain X-ray, and you may see the second fracture in the MRI, but is more better to be appreciated in the plain X-ray or in the CT scan. And you can see the empty notch sign and the abnormal configuration as well as the abnormal parenchymal signal of the anterior cruciate ligament. One of the weak signs of ACL rupture is known as PCL line sign. Normally, if you draw a line tangential to the vertical part of the posterior cruciate ligament, this line will cut the femoral surface. But if the ACL is ruptured and the tibia is displaced anteriorly, then this vertical part of the posterior cruciate ligament will be more vertical, and this is known as buckling of the PCL. Then if you draw a line tangential to the vertical surface, to the vertical course of the posterior cruciate ligament, it will not touch the femur. And if this occurs, this may be considered as a positive sign for ACL rupture. This sign, as I have mentioned, is a weak sign, and the most reliable signs are the bone marrow contusions and the anterior translocation of the tibia. Then how to diagnose partial ACL tear, which is a difficult diagnosis by MRI and even by endoscopy, as the orthopedic surgeon said. Then if you look to the ACL here, you cannot see that the ACL is stretched and is no more parallel to the roof of the intercondylar notch, but it appears somewhat of normal signal. Then if you see angulation or the ligament is lax, you may assume that this is partial tear of the ACL, which should be confirmed by arthroscopy. This is also a sign which is known as the single bundle sign, and you know that the ACL is formed of two bundles. If you see the ACL is intact in one sagittal image, the next image shows that the ACL is ruptured, then you know that one bundle is intact and the second bundle is ruptured, and this means that the ACL is partially torn. Then look at this ACL. What do you think? It's ruptured. Then look at the image before and you see that the ACL is more or less intact, and this is a single bundle sign. What are the diagnostic criteria of chronic anterior cruciate ligament tear? The most reliable sign is the fragmentation of the ACL. And if you look along the course of the ACL, you will see some fragments of the ligament, and you see some granulation tissue composed of edema and hemorrhage and so on. Then what about the tibia? It will be anteriorly dislocated. What about the bone marrow contusions? They will be resolved because this is a chronic ACL rupture. Then in order to diagnose chronic ACL rupture, the ligament is fragmented and is surrounded by granulation tissue. The empty notch sign will be positive, and the anterior translocation of the tibia will be positive, but bone marrow contusions will be resolved. And the torn ACL can be reconstructed by grafts, and sometimes you are requested to evaluate the integrity of the graft and if there is any possible complications. This is the ACL graft, and you know that there should be a femoral tunnel and a tibial tunnel, and they inserted the graft, which is made of hamstring muscle and of many other materials, of course, but this is one of the appearances. In order to judge the integrity of the graft, you look to the signal intensity of the graft, and in order to judge the attachment to the femur and the tibia, you will draw two lines. The first one is along the roof of the intercondylar notch, and the second one will be tangential to the posterior surface of the femoral shaft. Then, for the accurate or reasonable location of the graft tunnels, the tibial attachment should be posterior to this line, and the femoral attachment should be posterior to this line. Then once more, you see here a graft, and you draw two lines. The first one is parallel to the roof or going through the roof of the intercondylar notch, and the second one is tangential to the posterior surface of the femoral shaft. The tibial attachment is posterior to this line, and the femoral attachment is posterior to this line. Then the graft attachments are considered within normal. But here you can see that there is buckling and abnormal angulation of the graft itself, and this is inaccurate position of the tibial tunnel, and you see it's more vertical and it is more or less not going into the right way. Then also you should assess if the graft is intact or torn, and this is easy if you know the signs of rupture of the ACL, and there are the same signs of rupture of the graft itself, but you concentrate on the presence of abnormal signal within the graft substance. And many of the literature says that this abnormal signal should be evaluated after 6 months from the graft insertion, and any abnormal signal identified before that time is considered within the range of normal post-operative sequelae. Then after 6 months from graft insertion, there should not be any abnormal signal within the graft itself. Also, you know that there is a complication known as cyclops lesion, and this cyclops is a foreign body, let us say, or a mass of fibrous tissue, which is by arthroscopy it appears like an eyeball, hence the name. The exact etiology is unknown, but it is usually present here in the anterior part of the intercondylar notch, and this will hinder, of course, the movement of the joint, and you can appreciate the cyclops in this stir image and also in the axial image. There are some series for this cyclops lesion, and this is also an example. This is the ACL graft, and this is the site of cyclops by T1 and by stir images. These are the suggested possible causes of cyclops lesion. Number 1, excessive postoperative fibrosis, tissue fragments released from drilling during insertion of the graft, or gradual fraying and bunching up of the ACL graft fibers, either from the graft itself or from the drilling during insertion of the graft, or due to fibrosis initiated by the operation. Then one of the complications is known as the tunnel cyst, and this is a collection of fluid in one of the tunnels, either in the tibial tunnel or in the femoral tunnel. And these are the possible causes: incomplete incorporation of the allograft tissue, or the graft necrosis, or extrusion of the joint fluid into the tunnel. And the synovial effusion, it may have its way into one of the tunnels, and it will collect here and form what's known as the tunnel cyst. And this is an example of tibial tunnel cyst, intermediate signal in the proton density image and bright signal in this T2 fat suppressed image. Then we came to another issue regarding the ACL abnormalities, and this is known as mycoid degeneration of the ACL. By mycoid degeneration, we mean that there are degeneration of some of the fibers of the ACL while other fibers remain intact. In the images, you will see that the anterior cruciate ligament is swollen, and it shows abnormal increased signal in all pulse sequences. And if you look carefully, especially in the proton density image, you will see some of the intact fibers going through the swollen ligament. And this is exactly similar to this ciliary stalk. And if you look here, you can see that the ACL is swollen, and in the T2 weighted image and also in the stair image, you can see the fibers, some of the intact fibers similar to this appearance, which is diagnostic of mycoid degeneration. This is another example, the proton density and the T1 weighted image. The intact fibers are better appreciated in the proton and T2 weighted images. The ligament is markedly swollen and is of abnormal signal. This is diagnostic of ACL degeneration. Also, the ACL may be subjected to the development of an intraligamentous cyst, and these are ganglion cysts which occur, which affect the anterior or maybe the posterior cruciate ligament. The series include mucinous degeneration of the connective tissue or herniation of the synovial tissue through a defect in the joint capsule or tendon sheath. The end result is the formation of a cystic lesion filled with fluid within the substance of the anterior cruciate ligament. This is a good example, T1 and gradient image, and also here in the T2 weighted image, and you can see the fluid content of the lesion. This is also a good example, the anterior cruciate ligament, low signal in the T1, intermediate in the proton, high signal in the T2, and this is the difference between intercondylar notch cyst and the ACL mycoid degeneration. The cyst is a cyst containing fluid of bright signal in the T2 weighted image, but the ligament in the T2 weighted image is of relatively increased signal, and you can see some of the intact fibers going through the ligament itself. And you should remember the ciliary stalk or the ciliary appearance, and here you can see the intact fibers within the swollen ligament here and there. And you should know that mycoid degeneration may be associated with a ganglion cyst within anterior cruciate ligament. Both can exist in the same time. And here is an example. You see the swelling of the ligament and the fibers going through the ligament, as well as the cystic changes near its femoral attachment. This is also another example of mycoid degeneration of the anterior cruciate ligament with anterior cruciate ligament cyst near its femoral attachment. Sometimes you can see abnormal signals within the anterior cruciate ligament. And if the anterior cruciate ligament is stretched and is parallel to the roof of the intercondylar notch, then ask yourself, the abnormal signal seen in the T1 or in the T2. In both sequences, abnormal signal are considered within normal range if the ligament is stretched and is coursing parallel to the roof of the intercondylar notch. This is coronal T1, and you can see abnormal bright signal near the tibial attachment of the ACL, and this is fat within the intersects of the ligament itself. This is T2 weighted image, and you can see a high signal within the ligament, and this is synovial recesses within the ligament itself. Then when to consider these signals abnormal, whenever you see abnormal configuration of the ligament, such as swelling and abnormal parenchymal signal, which should be increased, then you start to consider these abnormalities as belonging to the original disease of the ligament itself. Then we came to the posterior cruciate ligament. The posterior cruciate ligament is a cord-like black signal structure attached to the posterior surface of the femur, going to the posterior surface of the tibia. Sometimes you can see very small dot of low signal anterior and another one posterior, like this. You see an anterior dot and a posterior dot, and these are the meniscofemoral ligaments. The anterior one is known as the ligament of Humphrey. The posterior one is known as the ligament of Wurzburg. Many times you cannot see these ligaments because they are of low signal, and the cruciate ligament is also of low signal, and they are usually masked by the signal of the PCL. But this is a very good presentation of these meniscofemoral ligaments. When to diagnose PCL tears? You know that the PCL is a cord-like low signal ligament passing from the posterior surface of the femur to the posterior surface of the tibia. The two major signs of rupture are: number one, a swelling of the ligament; number two, abnormal signal. Then here you see the ligament is swollen and there is heterogeneous high signal along most of the course of the ligament, diagnostic of complete rupture of the anterior cruciate ligament, of the posterior cruciate ligament. And this is also an example. You see there is an abnormal signal in the middle part of the posterior cruciate ligament, diagnostic of complete rupture. Another example, T1 and T2, and you can see the heterogeneous increased signal in the mid portion of the ligament, and most of the ligament also shows abnormal signal denoting complete rupture. Here is also another example of posterior cruciate ligament tear. The vertical part is of abnormal signal and is markedly swollen, diagnostic of being ruptured. Avulsion of the posterior cruciate ligament tibial attachment is more common than avulsion of the anterior cruciate ligament. In this example, you see that the tibial attachment of the posterior cruciate ligament is detached, but the posterior cruciate ligament itself shows normal size and the normal parenchymal signal. The fracture site will show some bone marrow edema, as you can see here, with increased signal intensity in this T2 weighted image. This is also another example of avulsion of the tibial attachment of the posterior cruciate ligament, and many times you can see that the posterior cruciate ligament itself is of normal parenchymal signal and also of normal size. The avulsion can be seen in the plain film and also can be better appreciated in the sagittal 2D reconstructed CT image. You see the fragmentation of the tibial attachment of the posterior cruciate ligament, and this is the MRI of the same case. You see a avulsion of the tibial attachment of the posterior cruciate ligament. This is another example with avulsion of the tibial attachment of the posterior cruciate ligament, corrugation and laxity of the ligament itself, and this is one of the ways of treatment of this kind of avulsion. Partial PCL tear is easy to diagnose compared to partial tear of the anterior cruciate ligament, because this ligament is cord-like, and if you can identify bright signal within the course of the ligament, then you assume partial tear. The upper fibers are intact, the lower fibers are ruptured. And then you remember that there is mucoid degeneration of the anterior cruciate ligament, and there is also mucoid degeneration of the posterior cruciate ligament. The posterior cruciate ligament will be somewhat swollen, and it will maintain its anatomic configuration, but it will show intermediate signal in all pulse sequences. No bright signals here, because bright signals will indicate complete rupture. But the swelling of the tendon with intermediate, swelling of the ligament with intermediate signal along its course indicates mucoid degeneration. And this is also mucoid degeneration of the posterior cruciate ligament. You see this intermediate signal within the course of the ligament. This patient had mucoid degeneration of 3 structures in the knee: the posterior cruciate ligament, the anterior cruciate ligament, and the posterior horn of the medial meniscus. Finally, we came to the collateral ligaments, and you know that we have the medial and lateral collateral ligaments, and we have 3 grades of injury: grade 1, grade 2, and grade 3. In order to diagnose these grades of injuries, you should know that the medial collateral ligament is long and is intimately related to the femoral and the tibial condyle. You can identify the medial collateral ligament by looking in the notch at the horizontal part of the posterior cruciate ligament, which is attached to the inner aspect of the medial femoral condyle. And you remember that the anterior cruciate ligament is intimately related to the lateral femoral condyle. This is the medial collateral ligament. Grade 1 injury means that the medial collateral ligament is intact, but there is some fluid signal along its course. This is known as grade 1 medial collateral ligament injury. Grade 2 injury, the ligament is relatively thickened. It is away from the femoral and the tibial condyles, and its course is surrounded by fluid signal. This is known as grade 2 medial collateral ligament injury. This is grade 2. The ligament is relatively thickened. It is now away from the medial femoral and tibial condyles and is surrounded by fluid signal, and this is grade 2 injury. Grade 3 meaning that complete disruption of the ligament, either at its femoral attachment or tibial attachment or at its mid portion. You see, the ligament is also surrounded by fluid signal. This is complete rupture of the medial collateral ligament near its tibial attachment with fluid signal surrounding the ruptured part. Medial collateral ligament rupture, this is the femoral attachment which is intact, and you see there is no ligament here, and you can appreciate the fluid signal around the course of the ligament. And because of this is a traumatic lesion, there may be some other manifestations of trauma, especially in the retinacular ligaments. And if you look here, this is the medial articular surface of the patella, and this is the lateral articular surface. The lateral patellar retinacula is intact, and the medial retinacula is not seen very good, and it is surrounded by fluid signal. Medial collateral ligament tear. You look in the notch here, and this is the medial side of the knee, and this is the supposed course of the medial collateral ligament, which is not seen along its whole course and is replaced by fluid signal diagnostic of its rupture. And this is lateral collateral ligament. You see, this is the fibula, and this is the site of the lateral collateral ligament. It should attach to the femoral condyle, but you cannot see this attachment, and you see this abnormal signal and corrugation of the ligament. And here the lateral collateral ligament is supposed to be there, but you cannot see the ligament at all, and you see instead some fluid signal at its anatomic site. This is the normal appearance of the lateral collateral ligament, and this is rupture, complete rupture of the lateral collateral ligament. هذا وبالله التوفيق والحمد لله رب العالمين.